Ocular Pathology Review, Part 6, Optic Nerve and Glaucoma. From the Department of Pathology at the Wills Eye Hospital and the Sydney Kimmel Medical College at Thomas Jefferson University. Optic nerve glioma, or juvenile polycytic astrocytoma, is strongly associated with neurofibromatosis type 1. This causes unilateral visual loss and axial proptosis. There's a fusiform intradural swelling of the nerve without orbital invasion. We see a proliferation of benign spindle-shaped pilocytic astrocytes. You may see clumps of eosinophilic filaments called Rosenthal fibers. There may be subarachnoid gliomatosis, giving rise to a biphasic appearance. A lot of lesions are followed. Surgery or radiation is used for cosmesis or threat of chiasmal involvement. Here's an example of axial proptosis.
With the kink, swollen nerve within its intact dural sheath.
Here's one of these biphasic lesions. We see the enlarged bundles of neoplastic nerve, top right, and proliferation of glial tissue in the arachnoid, so-called arachnoidal gliomatosis. These are Rosenthal fibers in an optic nerve glioma. Now, you can have malignant gliomas of the optic nerve in adults. Here's histopathology of the case we had a few years ago. This is essentially a glioblastoma of the optic nerve. It causes rapid blindness and rapid death. Meningiomas of the optic nerve can arise primarily from the meninges of the optic nerve. There can be secondary invasion from a CNS meningioma, or rarely they can arise from ectopic rests of meningothelial cells. Patients frequently have severe visual loss with minimal proptosis. They can have retinal choroidal venous collaterals in the discs, which have been termed optociliary shunts in the past. Imaging shows diffuse swelling of the optic nerve, possibly with enlargement at the orbital apex, with calcification. Again, this generally is a benign tumor of meningothelial cells. There are cases of rare malignant meningiomas.
But most of them are benign, but they may cause problems due to their location.
They may perforate the dura and invade the orbital tissue. In the optic nerve, the tumors typically are meningothelial or transitional. You can have paving stone clusters and whorls of cells. These typically have intranuclear vacuoles of herniated cytoplasm. And you can see psammoma bodies, which are sort of analogous to the corpora arenacea that we see in the normal arachnoid. The tumors express epithelial membrane antigen and vimentin.
The histopathology shows whorls of meningothelial cells and psammoma bodies.
Optic disc edema. This is a case of secondary optic disc edema due to a very, very small juxtapapillary melanoma. This case is very interesting. It was actually thought to be a neurological condition. Clinically, we had an opportunity to do histopathology on this case. You can see massive swelling of the optic nerve head. The tumor in the optic nerve sheath is seen at the lower left. There is lateral displacement of the photoreceptors and the typical Peyton's folds, which are seen in optic disc edema. The lateral displacement of photoreceptors is responsible for enlargement of the blind spot that occurs in optic disc edema. There's higher magnification, even higher, showing the
profiles of the markedly dilated axons. Papilledema is not due to extracellular edema. Swelling of the nerve is due to axoplasm blocked by distortion of the pores in the lamina cribrosa, caused by a pressure gradient.
Another example of optic disc edema showing the lateral displacement of the photoreceptors, the subretinal fluid, and retinal folds. Again, blockage of axoplasmic flow. Another case from the Armed Forces Institute of Pathology with lateral displacement of photoreceptors, responsible for enlargement of the blind spot. Optic disc drusen have no relation to drusen of the retinal pigment epithelium or the giant drusen, the astrocytomas of the optic nerve in tuberous sclerosis complex. These can be sporadic
or occur in families. There is a very low incidence of optic disc drusen in patients with retinitis pigmentosa.
We see calcified, concentrically laminated globular aggregates in the optic nerve anterior to the lamina cribrosa. Pathogenesis may involve blockage of axoplasmic flow with a narrow scleral canal. Mark Cho questioned whether calcified mitochondria might be a nidus for further calcification. This was a case of incidental optic disc drusen in a patient who had a juxtapapillary melanoma. The calcific bodies actually fractured during sectioning. This is a case of severe optic atrophy. Again, as we see in bottom right, the optic disc is too small for its meninges.
The mouse on trichrome stain at top right shows massive atrophy and fibrosis of the optic nerve. Almost half of the parenchyma of the nerve is replaced by fibrosis, which stains blue. Schnabel's cavernous optic atrophy is a rare condition that used to show up very often on examinations, characterized by the presence of pools of hyaluronic acid in the retrolaminar part of the optic nerve. This initially was thought to be due to vitreous that was propelled into the nerve by high intraocular pressure. However, autopsy studies have shown similar changes in patients without glaucoma, suggesting that there may be synthesis of the material in situ. Schnabel incorrectly believed that glaucomatous cupping was caused by collapse of the optic nerve head into the retrolaminar cavities. The material stains positively for mucopolysaccharide, and staining is abolished by pretreatment with hyaluronidase. These photomicrographs show the colloidal iron stain for mucopolysaccharide before and after hyaluronidase digestion. We rarely see Schnabel's cavernous optic atrophy in the laboratory. It essentially is a medical curiosity that has been overemphasized in examinations in the past.
Here's an old definition of glaucoma by Nana back in 1980. A syndrome characterized by an elevation of intraocular pressure of sufficient degree or chronicity to produce tissue damage. This definition is somewhat out of date. It includes intraocular pressure, and intraocular pressure is now thought to be only one of the risk factors. It does have some other important things about it, however. It stresses that it's a syndrome, that a lot of the different mechanisms can elevate intraocular pressure, and it also emphasizes that tissue damage has to be documented to make the diagnosis. A single elevated pressure is not glaucoma. Here's a more recent definition, not that recent anymore, by Harry Quigley, an optic neuropathy associated with a characteristic excavation of the optic disc and a progressive loss of visual field sensitivity. Now, this definition does not mention intraocular pressure. If you go on the internet and look up for definitions of glaucoma, most of them do mention intraocular pressure. One of the exceptions is a definition from a glaucoma society. But it still emphasizes the fact that elevation of intraocular pressure is a very important risk factor, and it's the only thing you can really treat. Intraocular pressure, of course, is maintained by a production and drainage of aqueous humor. The primary outflow pathway for aqueous humor is in the angle formed by the iris and cornea. Primary outflow pathway is the trabecular meshwork. Of course, we know that a small amount of aqueous also goes out through the iris and through the ciliary body, through the posterior scleral outflow pathway. Okay, here's the trabecular meshwork in the periphery of the anterior chamber. It's called trabecular meshwork because it's composed of small beams or trabeculae of collagen enveloped by trabecular endothelial cells. Let's follow the aqueous humor across the iris into the angle. You can see the trabecular meshwork in the scanning microscopic movie. And moving to the side of the specimen, we can see the angle. With the canal schlemm, trabecular meshwork, and the scleral spur. Canal schlemm, trabecular meshwork, and scleral spur. Again, Janoff's definition states that you have to demonstrate tissue damage. Well, you look for glaucomatous retinal atrophy and glaucomatous optic atrophy. Glaucomatous retinal atrophy is characterized by the loss of ganglion cells and nerve fiber layer axons, shown here in this photomicrograph. Now you see loss of ganglion cells and axons in both primary optic atrophy or glaucomatous optic atrophy. Primary optic atrophy could, if you have a tumor compressing the nerves or somebody has their optic nerve cut during trauma, they'll get primary optic atrophy. They'll get a white disc, but only glaucoma has cupping, suggesting the role of intraocular pressure. Here's a case with the yellow spot or macula lutea and a end-stage glaucomatous bean pot cup. Again, scanning micrograph showing end-stage glaucomatous cupping. This is a bean pot. For those who don't live in Boston, we see massive cupping and excavation of the optic nerve head with posterior bowing of the lamina verbosa. Glaucomatous optic atrophy. Here's a scanning micrograph, a longitudinal section through the optic nerve. See the lamina verbosa here. In a normal eye, at least half of the thickness of the retina at the margin of the disc is composed of nerve fiber layers, we see in this photomicrograph. Okay, here's a glaucomatous cup scanning micrograph in comparison. Here's a similar histologic section. We see very little or no nerve fibers entering the cupped out disc in this case, and we can also see severe glaucomatous atrophy of the retina. Primary congenital glaucoma. Primary congenital glaucoma is typically autosomal recessive. It affects both eyes. Interesting symptoms include tearing, photophobia, and blepharospasm. The cornea is enlarged and there is ectasia of the limbal tissues as well. Ruptures occur in Descemet's membrane. These are called hopstriae. They tend to be horizontal or concentric to the limbus peripherally. The angle is open and there's high insertion of the iris root. And patients have buphthalmos. What's buphthalmos? Buphthalmos means ox eye. The appearance of the cornea has been likened to the eye of a cow or an ox. Here's a woman from California who was dissecting a cow's eye on the internet, and I think it's a pretty good analogy. And here's a histologic section from Myron Janoff's collection showing the enlarged cornea and the ectasia of the limbal tissues, the deep anterior chamber. This patient also has a rupture in Descemet's membrane, which we'll see under higher magnification in this photomicrograph, the typical coiled Descemet's membrane after a rupture. And as we said before, hopstriae are Descemet's membrane ruptures in congenital glaucoma, and they tend to be horizontal or concentric to the limbus peripherally. Now, developmental glaucoma can occur in several syndromes. We have glaucoma associated with iris abnormalities like Rieger syndrome, Peters anomaly, or aniridia. Can occur in phacomatoses, typically neurofibromatosis type 1 and Sturge-Weber syndrome. Can be associated with congenital rubella, Lowe's oculocerebrorenal syndrome, Stickler syndrome, the Pierre-Robin anomaly, Howard-Lehmann-Streiff syndrome, and in some of the chromosomal abnormalities, typically trisomy 21 and 13, and may occur in Hurler syndrome. This is a remarkable case. This is a child that has congenital aniridia, and the corneal diameter here is 18 millimeters. Here's a child with neurofibromatosis type 1 the plexiform neurofibroma involving the right upper eyelid, and corneal enlargement consistent with ophthalmos. We had the opportunity to process this eye when I was a fellow at the AFIP. Generally, it's said if the upper eyelid is involved, the patient's at risk for developing glaucoma. Scanning microscopy of the angle of that eye shows the absence of the trabecular meshwork. There is so-called hamartomatous infiltration of the angle structures, leading to the distinctive gonioscopic appearance of NF1. Primary open-angle glaucoma is the most common form of glaucoma in the Western world, responsible for 2/3 of cases in Caucasian individuals. There is elevation of intraocular pressure, which is insidious in origin. The angle is open on gonioscopy. The condition is bilateral, and heredity is very important. It is more common in African American patients. In the Baltimore Eye Study, the incidence in African Americans was 11.3% compared to 2.2% in Caucasians. It tends to be poorly understood. There are many pathogenic theories, and the block to the aqueous outflow is thought to reside in the juxtacanalicular connective tissue. Some of the pathogenic theories that have been talked about in the past include giant vacuoles in Schlemm's canal. This was Tripathi's theory. Decreased trabecular endothelial cell density. Nice paper by Alvarado's group. Reduced area of meshwork cul-de-sacs bordering the juxtacanalicular connective tissue. Deposition of certain materials in the juxtacanalicular connective tissue, like plaque, glycosaminoglycans. Again, mutant gene product of the GCL gene called myocillin. There's also been questioned whether there's decreased CD44H and hyaluronin in the juxtacanalicular tissue. And Ben Fine postulated that there could be blockage of posterior outflow due to sclerosis at the scleral spur. Here's a histologic section through the trabecular meshwork. We see fusion of some of the beams, and this may be related to loss of endothelial cells, leading to fusion of the beams and to decreased meshwork porosity. Primary closed-angle glaucoma. A red eye with dilated pupil is acute closed-angle glaucoma, or an acute attack until proven otherwise. Note the shallow anterior chamber in the fellow eye. Primary closed-angle glaucoma has an anatomic predisposition for small hyperopic eyes with crowded anterior segments, more common in Asians. Chronic angle closure glaucoma is also common in Asia. It's rarely seen before age 40. Again, shallow anterior chamber with a narrow angle. The acute attack is very symptomatic. The eye is red, it's painful, there's a steamy cornea. The pupil becomes fixed and dilated due to ischemia, and patients may have gastrointestinal symptoms like nausea and vomiting. Remember when I was an intern, there was a type 1 diabetic, a young woman who was admitted to the medicine service for diabetic control. She had nausea and vomiting, and she actually had neovascular glaucoma. There are functional pupillary block or plateau iris mechanisms. An iridotomy relieves the pressure gradient and allows the angle to open. Peripheral anterior synechia develop. After an acute attack, there are certain stigmata of the attack. These include segmental iris atrophy,
due to focal ischemic iris necrosis,
a fixed dilated irregular pupil due to atrophy and necrosis of the sphincter and dilator muscle, and glaucoma flecken, which are little focal cataractous changes
due to anterior lens epithelial necrosis.
Papilledema also may occur in primary closed-angle glaucoma
due to blockage of axoplasmic flow in the pores of the lamina cribrosa that are distorted by the pressure gradient between the eye and the optic nerve.
If a patient with a narrow angle is dilated, with dilating drops, a functional pupillary block may occur. This leads to elevation of pressure in the posterior chamber, which bows the peripheral iris forward, blocking the angle. An iridotomy or iridectomy equalizes the pressure in the anterior and posterior chambers. It does away with the pressure gradient
and allows the iris to drop back and relieve the angle closure. In his Jackson Memorial Lecture at the American Academy of Ophthalmology several years ago, Dr. Harry Quigley discussed several factors involved in acute angle closure glaucoma. These include low iris volume loss on dilation, plateau iris configuration, a small eye with high iris lens channel resistance, and choroidal expansion. Poor vitreous conductivity was thought to play a role in malignant glaucoma. Secondary closed-angle glaucoma is characterized by the formation of permanent adhesions between the iris and peripheral cornea called peripheral anterior synechias. The angle is open in the macro photo above. Pigment is seen in the thickest portion of the trabecular meshwork, just anterior to the scleral spur, and a faint band of pigment marks the termination of Decime's membrane at Schwabe's line. In the macro photo below, the trabecular meshwork is totally hidden and blocked by multiple irregular peripheral anterior synechias. An open and closed angle are compared in these photographs. In the photomicrograph of the open angle at bottom left, the trabecular meshwork and Schlemm's canal are seen nestled in the anterior crotch of the scleral spur. In the closed angle at bottom right, the peripheral anterior synechia completely occludes the trabecular meshwork.
Here's another example with a flat iris and a peripheral anterior synechia. This was caused by neovascularization of the iris after an old central retinal vein occlusion. You see a flat iris histopathologically or clinically, that suggests something's growing on it, and that typically is neovascularization. The flattening of the iris may not be that obvious clinically unless you really look for it,
because the membrane is transparent.
Again, here's examples of rather narrow peripheral anterior synechias blocking just part of the trabecular meshwork.
There are many causes of secondary closed-angle glaucoma. Peripheral anterior synechias can develop if acute angle closure glaucoma is not treated. Synechias can also develop in cases of persistent flat chambers due to wound leaks. There are multiple mechanisms for pupillary block. These include posterior synechias due to inflammation, phacomorphic glaucoma due to an enlarged intumescent cataract, an absent or a non-patent iridectomy, and blockage of the pupil by vitreous, a dislocated lens, or microsphere phakia in the case of Weill-Marchesani syndrome. Secondary angle closure is also caused by anterior displacement of the lens iris diaphragm. In eyes with posterior tumors, exudative retinal detachments, or hemorrhagic retinal detachments. The latter has been reported in patients with age-related maculopathy who are on anticoagulant therapy. Aqueous misdirection or malignant glaucoma is another cause. Cellular proliferation on the iris and angle can also lead to secondary closed-angle glaucoma. Examples of the so-called secondary proliferative glaucomas include neovascular glaucoma, epithelial downgrowth, and the iridocorneal endothelial or ICE syndrome. Neovascular glaucoma is the most common type of secondary glaucoma seen in the ophthalmic pathology laboratory. This photo shows iris bombée due to 360-degree posterior synechias due to inflammation. The term seclusion of the pupil is applied to 360-degree posterior synechias. Occlusion of the pupil refers to a pupillary membrane. Patients with a Weill-Marchesani syndrome have a small round microsphere phakic lens. This initially is responsible for high degrees of lenticular myopia. As the patient ages, the microsphere phakic lens migrates anteriorly, blocking the pupil and causing secondary angle closure that can be alleviated by dilating the pupil. Neovascular glaucoma is caused by VEGF, or vascular endothelial growth factor, produced by ischemic retina. The resultant fibrovascular membrane flattens the anterior surface of the iris. In addition to new vessels, the membrane contains myofibroblasts, which probably provide motive force for synechial closure and ectropion of the iris pigment epithelium and sphincter muscle. Important causes of neovascular glaucoma include proliferative diabetic retinopathy and ischemic retinal vein occlusions. Intraocular tumors can also produce VEGF. Neovascular glaucoma in a child should raise the possibility of an intraocular tumor. 43% of 297 eyes enucleated for retinoblastoma had neovascularization of the iris, and 26% had frank neovascular glaucoma.
NVI and NVG were more common in eyes with high-risk histopathologic features. 70% of the eyes with high-risk features had neovascularization of the iris, and 60% had neovascular glaucoma. Other causes include anterior segment ischemia or necrosis, ischemic oculopathy, and chronic retinal detachment. Here's a case of neovascular glaucoma in a patient with diabetes mellitus. The angle is occluded by a peripheral anterior synechia. You can tell that the patient has diabetes due to the lacy vascularization of the iris pigment epithelium. Clinically, iris neovascularization is often called rubeosis iridis, which means a reddish discoloration of the iris. Any vessel found on the anterior surface of the iris is pathologic. This is a scanning micrograph of a normal iris showing the typical anatomic features, the collarette, the crypsofuchs, the contraction furrows. In contrast, this is an iris from a patient with neovascular glaucoma who had an attempted filtering procedure. That's why the iridectomy is present. Note that the entire anterior surface is flattened and effaced by the neovascular membrane. Another scanning micrograph from a patient with neovascular glaucoma after vein occlusion. Again, there's a broad peripheral anterior synechia, and the iris is flattened and effaced by the neovascular membrane. Another case, a florid neovascular membrane in a diabetic patient. This has produced ectropion of both the sphincter muscle and the iris pigment epithelium. This is a high magnification scanning electron micrograph of the anterior surface of the iris in a patient with neovascular glaucoma. Initially, when I tried to take teaching scanning micrographs of neovascular glaucoma, I could never find the vessels. I couldn't find them because they were always buried by this sheet of cells, which is transparent clinically. The sheet of cells covering the new vessels contains myofibroblasts, shown in the electron microscopic inset. This macro photo of neovascular glaucoma shows the iris flattened by the transparent sheet, which has produced ectropion of iris pigment epithelium and sphincter muscle. This photomicrograph shows corneal epithelium that has invaded the interior of the eye, growing on the surface of the iris in a case of epithelial downgrowth or ingrowth. Proliferative endotheliopathy with iris abnormalities was actually the title of our original paper on the iridocorneal endothelial, or ICE syndrome. The iridocorneal endothelial syndrome was a secondary title. This syndrome comprises a spectrum of rare unilateral glaucomas that typically are found in young to middle-aged women. In these patients, a proliferation of abnormal corneal endothelium causes secondary closed-angle glaucoma and interesting secondary iris abnormalities that include flattening and effacement of the anterior surface of the iris with pigmented nodules in the Cogan-Reese or iris nevus syndrome end of the spectrum, and tractional iris holes in essential iris atrophy. Chandler syndrome typically has corneal edema at low elevations of intraocular pressure. This clinical photo shows the case initially reported by Cogan and Reese. The left-hand portion of the iris appears normal. In the right-hand part of the iris, the normal anatomic landmarks are flattened and effaced by a membrane that includes multiple pigmented iris nodules. Ectropion of the pigment epithelium also was present. This eye was enucleated because the patient was thought to have a melanoma. Histopathology shows ectopic Descemet's membrane on the anterior surface of the iris. Production of new Descemet's membrane material is interposed between the iris and cornea in the area of synechial closure, suggesting that it played a role in the pathogenesis of the angle closure. A pigmented iris nodule also was noted. The iris nodules are a clinical marker for iris endothelialization, shown in the inferior iris to the ectropion of the pigment epithelium in this eye with essential iris atrophy and a full-thickness iris hole. In the photomicrograph at right, the PAS stain highlights large quantities of new Descemet's membrane in the area of synechial closure, in another case of essential iris atrophy. The presence of the new Descemet's membrane in this location suggests that it was present prior to angle closure and was a factor that contributed to its pathogenesis. So to summarize, ICE syndrome is unilateral closed-angle glaucoma with secondary iris abnormalities caused by abnormal endothelial proliferation. Cogan-Reese or iris nevus syndrome is characterized by flattening and effacement of the iris stroma by the endothelial membrane and nudescimase membrane with pigmented iris nodules. Chandler syndrome has corneal edema at relatively low elevation of intraocular pressure. In essential iris atrophy, there are full-thickness tractional holes in the iris. Clinically, the corneal endothelium appears dystrophic, with dark light reversal noted on specular microscopy. Synechia is also formed focally in the open angle. Secondary open-angle glaucoma is caused by cells or material in the anterior chamber and angle. This can include blood and blood breakdown products, inflammatory cells, lens material, or tumor cells. Melanin release from the iris pigment epithelium causes pigmentary glaucoma. Pseudoexfoliation is an important cause of glaucoma in some areas. In the exceedingly uncommon condition called the Schwarz-Matthieu syndrome, the trabecular meshwork is blocked by photoreceptor outer segments shed by a chronically detached retina. These enter the anterior chamber through a retinal dialysis. Blockage of the trabecular meshwork by fragments of zonular fibers were reported in the era of enzymatic zonulysis in cataract surgery. In the lytic glaucomas, the open angle is blocked by macrophages. These include macrophages that have ingested denatured lens material released from a leaking Morgagnian cataract in phacolytic glaucoma, macrophages that have ingested melanin released from necrotic intraocular tumors in melanomalytic or melanocytomalytic glaucoma, and blood breakdown products including erythrocyte ghost cells and hemosiderin in hemolytic glaucoma. In ghost cell glaucoma, degenerated erythrocytes called ghost cells or erythroclasts released from chronic vitreous hemorrhages can block the open angle.
This clinical photo shows the milky appearance of the anterior chamber in a patient with phacolytic glaucoma. The anterior chamber contains degenerated lens protein released from a chronic Morgagnian cataract. This photomicrograph of phacolytic glaucoma shows eosinophilic lens protein in the anterior chamber. A few aggregates of lens-laden macrophages adhere to the anterior surface of the iris. The patient also appears to have a recessed angle. This vitrectomy specimen from a patient with phacolytic glaucoma shows numerous lens-laden macrophages and fragments of cataractous lens material. In this case of melanocytomalytic glaucoma, numerous macrophages fill the anterior chamber and infiltrate the interstices of the trabecular meshwork. Melanophages blanket the trabecular meshwork in the scanning electron micrograph at bottom left. Macrophages that have ingested hemosiderin are seen at bottom right. The arrow points to an erythrocyte ghost cell. Melanophages blocking the trabecular meshwork, in this case of melanocytomalytic glaucoma, are seen under higher magnification in this scanning micrograph. The pigment dispersion syndrome causes pigmentary glaucoma about 50% of the time. The dispersion of pigment is caused by abrasion of the iris pigment epithelium by bundles of zonular fibers. The condition often occurs in young myopic males who have iridodenesis. Clinical features include a vertical Krukenberg spindle in the center of the cornea, radial iris transillumination defects, and marked pigmentation of the trabecular meshwork. Inverse pupillary block is thought to contribute to the zonular abrasion. A Krukenberg spindle is seen in the slit lamp photo. The granules of iris pigment epithelial melanin are present in the cytoplasm of the corneal endothelial cells. Radial iris transillumination defects are seen in this case, originally reported by Yanov and Shea. The location of the transillumination defects corresponds to the valleys between adjacent ciliary processes where the bundles of zonular fibers are located. The arrow in the scanning electron micrograph points to an area of pigment epithelial abrasion. Perform scanning microscopy on archival tissue from Yanov's case. The trabecular meshwork in this case is intensely pigmented. The photomicrograph shows that the pigment is present within the cytoplasm of the trabecular endothelial cells. The scanning electron micrograph of the trabecular meshwork shows numerous large round granules of melanin consistent with origin from the iris pigment epithelium. These observations are consistent with Campbell's theory. Another clinical feature of pigment dispersion syndrome is the presence of melanophages located in the anterior stroma of the iris, shown in these photos. This patient had striking iris transillumination defects. Whereas pupillary block has been found in some cases of pigmentary glaucoma, shown here in these photographs from the New York Eye and Ear Infirmary. The higher pressure in the anterior chamber bows the iris posteriorly where it is subject to zonular abrasion. The iris assumes its normal configuration after laser therapy.
Intraocular tumors can cause glaucoma. Posterior segment tumors typically cause closed-angle glaucoma through a pupillary block mechanism or by stimulating neovascularization. Anterior segment tumors typically are associated with open-angle glaucoma, caused by seeding or direct infiltration of the trabecular meshwork. This photomicrograph shows an iris melanoma directly infiltrating the ciliary body, the trabecular meshwork, and the canal of Schlemm. Eyes with retinal detachments tend to be slightly hypotenuse. An eye with a total retinal detachment and glaucoma harbors an intraocular tumor, typically a melanoma, until proven otherwise. The large choroidal melanoma seen in this macro photo has produced a high bullous retinal detachment, causing pupillary block and anterior displacement of the lens iris diaphragm. The anterior chamber is obliterated by total anterior synechnias. Ultrasonography should be used to exclude tumors in eyes with total detachments and glaucoma. Corneoscleral and extraocular disease can also cause secondary open-angle glaucoma. Glaucoma occurs in some patients with chronic luetic interstitial keratitis. Glaucoma caused by elevation of episcleral venous pressure can complicate sinus thromboses or mediastinal syndromes. Arteriovenous fistulas, like carotid cavernous fistulas, can cause arterialization of the episcleral veins. Pressure on the globe can also elevate intraocular pressure. Causes include retrobulbar tumors, tight encircling bands and retinal detachment surgery, and the large extraocular muscles in patients with thyroid ophthalmopathy. The patient shown here had a cavernous sinus thrombosis. This photo shows arterialization of an episcleral vein in a patient with a high-flow carotid cavernous fistula. Glaucoma caused by elevation of episcleral venous pressure is very difficult to manage.